نعم.
اوكي. نحط الهاتف على الصامت. airplane mode. كيف الأجواء عندكم دكتور مازن في الإمارات؟
لا يزال حر والله.
احنا ابتدى البرود شوية، ولكن اليوم كويس، درجة الحرارة 27.
لا نحن لسه عندنا بالأربعينات يعني. مع رطوبة عالية كمان.
لا احنا قالوا 27، قالوا هذا الويكند حيكون وورم. لا نزلت الأيام اللي فاتت عند 12 11 10 هكذا.
لا بس الجو حلو عندنا بالمول.
ايه بالمول.
فاللي بده يروح يشم هوا بيروح على المول.
دكتور منير، انتم دائما في الوسط ما شاء الله، دائما بريطانيا.
نحن نفس عندكم، نفس الطقس، بردت شوي بس مطر وهيك، بس ماشي الحال، تعودنا.
في أي مدينة دكتور منير؟
كوفنتري، يعني almost 2 hours north of London.
ما شاء الله.
بس أنا زرته للدكتور منير ببيته، شو بيعمل كبة حلبية يعني لهلا طعمتها تحت الأسنان مثل ما بيقولوا.
خلاص بانتظار زيارتك أنت والدكتور قديح والجاي طبعا، وكل الزملاء أهلا وسهلا بيتكم.
إن شاء الله.
إن شاء الله. الله يجزيك الخير وسلم البيت وأصحابه سيدي.
شرف.
الله يزيدك شرف.
بارك الله فيك.
دكتور طارق دائما متقل حاله علينا. بالمناسبة لازم نبدأ بقى نحضر للسلسلة الجديدة تبع السنة القادمة إن شاء الله، لأنه يمكن بقيان شي 3 محاضرات على ما أظن بهي السنة، فبدنا بقى شوي تكون أدفانس. بتتذكروا أول ما بدينا قلنا إنه في قسم ممكن نتركه للسنة الجاية إن شاء الله، فما رأيكم؟ دام فضلكم.
تمام، فينا نستخدم مواضيع جراحية أكثر تكون.
نعم.
نعم.
أنا جدا سعيد. الله يجزيكم الخير يا سيدي. أنا جدا سعيد إنه نحن غطينا جزء كبير من البيزك، فهو دائما مثل ما بيقولوا إنه اللي ما له قديم ما له جديد، فنحن بنقول اللي ما له بيزك ليس له أدفانس، فاللي ما بيعرف البيزك بيوقع بمطبات الجراحة حتى لو كان technically is very good one.
صح 100%. 100%.
الحمد لله. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello everybody. Good morning, good evening, good afternoon, wherever you are. And you are welcome to this session, and which we expose that to be very exciting session as usual, which will be presented by Dr. Gdih. And I'd like to thank Dr. Gdih for his efforts, and to thank as well Dr. Munir for being a panelist today and for the support to the glaucoma series. Today we are going to listen to Dr. Gdih about the major landmarks in glaucoma, RCTs, or the randomized clinical trials. Of course, we will learn a lot, because even if you are expert, you may need to stop sometimes and to reorganize the weapons that you have in order to get the best results. So now we are going to listen to the evidence-based and we are going to learn a lot from Dr. Gdih and from of course, the discussion that will be with Dr. Munir as well. Please, Dr. Gdih, the microphone is yours.
Thank you, Dr. Mazen. I will share my screen and let me know if it is visible.
It is.
Okay, so Assalamu alaikum, everyone, wherever you are. This lecture, I hope it would not pass 1 hour. I think it's content, short, and very focused to the point. We will try not to exceed 50 minutes. That's my goal. But my goal over the next 50 minutes is to review some of the major glaucoma randomized controlled trials. And we will try to answer what is different now in glaucoma management since 1993. And then we'll try to give a summary of available evidence to approach different types of glaucoma. And now why we selected randomized controlled trials is, randomized controlled trials in the scale of evidence, they have the highest evidence, and that's why we selected those. So going back to 1993, these are those are the major controlled trials that have been conducted in glaucoma. And if you see, I put the duration of these studies, like beside each one of them. So you see some of them, the least duration was 5 years. So they mostly run for 7, 8, or 9 years. And that's a lot of effort. And if you look at how much the people back then have put into medicine and how they try to help the newer generation, it's not something that you can ignore easily. So that's why we have to focus on them and then see what's collected from them. And then if you look, all of their goal is to prevent ocular hypertension from going to become advanced glaucoma, how we can run away from advanced glaucoma stage. So what are the possible scenarios when you're facing a glaucoma patient? Let's say every one of us see glaucoma patients. And then when you see a glaucoma patient in your practice, you have one of the 4 scenarios. It's either an early stage of pre-POAG, high IOP, but no glaucoma damage. Or you could see early stage, but they are well controlled on medical therapy. Or you could see early stage, but uncontrolled pressure on medical therapy. Or you could see advanced stage on medical therapy alone. And then you wonder, should you intervene or should you not? So these are the questions that each one of us will face. And then after reviewing all these RCTs, I am very confident that every one of you will have a better grasp of what to do if you face one of these scenarios. So we'll kick off with a case, just to stimulate thinking. There is no right or wrong, okay? So we just, every one of you read the case, and then tell me what would be your next step. Like, you don't have to tell me, just tell yourself, just think about it. So we have a 65 years old Black female. She's phakic with advanced POAG, right more than left. She is currently using Cosopt and Alphagan in both eyes. She's allergic to prostaglandin, so we cannot use that. Her best corrected visual acuity is 20/20 on both eyes. Her pressures are 28 on the right and 25 on the left. Gonioscopy revealed open angles with +2 pigmentation and flat iris. Her cup to disc ratio is 0.95 vertically with inferior notch on the right eye and 0.85 vertically on the left eye with thinned rim temporally. And visual field shows a dense superior arcuate scotoma on the right eye and a nasal step on the left eye. Now what? What would you do? Just think about an answer in your mind, and then let's look at this again when we review some of the studies. So that's why all these RCTs are focused on a different aspect of things. So that's where the advanced glaucoma intervention study. So if you look at this lady, she has advanced disease, and we need to intervene. So we need to get her down because she already lost a lot of field, and she is pretty cupped, and she still have a high pressure. So advanced glaucoma intervention study. The purpose of this study is to assess the outcome of sequences of laser and surgical treatment in eyes that have failed medical therapy. The outcome, the primary outcome, was decreased visual loss, and the secondary outcome is better IOP control, number of medication, complication rate, and failure of intervention. So the method, as I explained, it's a randomized controlled trial. They have the highest evidence of in the scale of evidence. The patients included in the study had moderate to advanced glaucoma. They had uncontrolled pressures on maximum tolerated medical therapy. They were randomized to 2 groups, and 2 surgical strategies were followed. Some of them started with TRAB, and then laser, and then TRAB, or ALT at that time. They didn't have SLT at that time. And then, or randomized to ALT first, and then TRAB, and then a second TRAB. So the groups are TAT or AT. They included about 600 patients, and they followed them for more than 5 years. So what they found is that they found different results in different ethnic groups. For African, they had worse visual field defect. They had less visual field and visual acuity loss with ATT, with laser first. So they did better with laser first. Now, I'm not telling you to do this, but this is just a finding that might help you when you face a patient, and then you might say, okay, I might use this because it has helped. This is proven by this study. And then the Caucasian group, they had less visual field and visual acuity loss with TAT, with TRAB, laser, and then TRAB again. So they did better with a TRAB first. Now keep in mind, every study has a limitation, and the limitation of this study is that they did not, we cannot adopt this completely into our current practice, because at that time, there was no prostaglandin, and there was no anti-metabolites used in trabeculectomy, because that increased the success rate of TRABs. But it's something to look at. So predictive analysis of AGES, or Advanced Glaucoma Intervention Study, they found 3 groups based on their mean IOP. They found a group they grouped them into people with more than 17.5 millimeter of mercury pressure, and they found they put another group between 14 to 17.5, and a third group less than 14. And what they found is that worse visual fields with IOP more than 17. Lower IOP predictive of doing well. So we will see this message across the board, like with all the studies, like the most effective treatment in preventing progression in glaucoma is lowering IOP. And then you have to look at other factors. But this finding has been repeated over and over. It just gives us more evidence. Associative analysis, where they group people into 4 groups as well, and they divided them by percentage of visits with pressure less than 17.5. So people who came all the visits with 100% of the time of their all visits had a pressure of less than 17, or only 17%, 75 to 100% of times of visits, they had a pressure of less than 17.5, and visits, 50 to 70% of their visits, they were less than 17, or less than 50% of their visits had less than 15. So guess who did the best? Of course, the group who came that had the greater percentage of visits with a pressure less than 18, those are the ones who did the best in all these participants. Other findings of AGIS is increased risk of cataract with TRAB, risk for TRAB failure were young patients, high intraocular pressure to start with, diabetes, and post-operative complications if they had to go back and forth with a complication. Those they had the highest failure rate. Decreased IOP was associated with decreased visual field progression. It was protective role for decreasing the IOP. Advanced glaucoma, the lower the lowering the IOP to low teens, most will not progress. If you lower to low teens, this helps you set up your target pressure. So most people with advanced glaucoma who had their pressure in the low teens meaning 15 or less, most of them will not progress. Okay, now I'm trying to introduce another study, so I'm going to stimulate another question. So which case will likely progress among these two cases? Let's take a minute to read the two cases. Case number one is 67 years old Caucasian female patient with presenting IOPs of 19 on the right and 17 on the left. Open angles, CD ratio of 0.9 right eye with superior pit and flame hemorrhage, and 0.85 left eye with central pit. Visual field showed dense inferior arc width on the right eye and deep paracentral scotomas on the left eye. Okay, case number two. 45 years old Asian male presented with pressures of 14 on both eyes. Cup to disc ratio was 0.7 both eyes with bilateral inferotemporal thinning of the rim. No disc hemorrhage noted, and visual field showed bilateral deep paracentral scotomas. So which one which one is likely to progress? I mean, you have different findings, different age, different ethnicity group, different cup to disc ratio, different pressures. So just think about it. You don't have to answer. Just keep the answer to yourself. This introduced us to normal tension glaucoma study. So normal tension glaucoma study was done to question or to answer two questions. Does IOP play a role in normal tension glaucoma? Does decreasing IOP by 30% will reduce the rate of progression? The main outcome was visual field progression or changes in the optic nerve. The secondary outcome was decreased visual acuity. So again, it's a randomized controlled trial, about 230 patients involved. They had to have one or both eyes with visual field defect and optic nerve changes. No untreated IOP of more than 24, otherwise it will be classified as a high pressure glaucoma. Average IOP was less than 20. No confounding ocular disease, meaning they excluded people with confounding ocular disease, systemic medication, and previous surgery. So they're just purely version non-normal tension glaucoma patients. They randomized people to control group, no treatment, they just watched them, and to the experimental arm, where 30% reduction from baseline, where they reduced their pressure by 30%. either by medicine or by surgery, either by drops or surgery. And let's see what they found. 2/3 of untreated arm did not progress over 5 years. So this is a piece of information that you can keep in mind when you see someone with a normal tension glaucoma and they ask you, doctor, am I going to go blind? You can tell them, 2/3 of patients who were not treated and they have normal tension glaucoma did not progress or did not develop blindness in 5 years. But 1/3 progressed on treatment, even though they were on treatment. So you can tell them, 2/3 of people, even if you don't take treatment, there is about 66% chance you will not change. But even if we treat you, there is about 1/3 chance of you, losing some visual field and visual acuity. And then when they looked at those people who progressed, those 1/3, they found that 1/3 of them, half of them, like 50% of them, their progression was IOP dependent, and the other 50% were IOP independent. So what are these other factors? So normal tension glaucoma is not only pressure. Yes, pressure does involve into the mechanism of their loss, but they have other factors we should keep in mind. Those other 50% with IOP independent had risk factors like older age, female, migraine, disc hemorrhage on presentation, higher baseline IOP, like they're presenting IOP, worse mean deviation, and pseudo-exfoliation material. So the results in treatment group, 30% reduction in IOP achieved in half without surgery. So they were able to get people down the 30% reduction in their pressure in about half of them without surgery. Initially, no difference between the groups, okay, between surgical or medical. And then 35% of controls versus 12% of treated group progressed. So people who were under control group, 35% of them progressed, and 12% of them, 12% of the treated group also progressed. So IOP does play a role in normal tension glaucoma. Also, this study supports 30% reduction in IOP in patients at risk of progression. 2/3 of untreated patients will not progress. Treatment, that means treat only those at risk. Treatment ideally should be low in side effects. Some patients will still progress despite 30% reduction in IOP. And those, as I said, are the IOP independent factors. Now, after we reviewed the normal tension glaucoma study, which case will likely to progress? 1 or 2? Just read them again and tell me. You can answer in the chat group, like in the everyone just write in the chat 1 or 2. Okay, thank you. So I think the message is clear now. Yeah. Okay. Another stimulating case for the next study. We have a 55-year-old Jamaican male patient with no significant prior ocular history. His first presentation with pressure of 34 in the right eye and 40 in the left eye. His slit lamp exam showed no pigment dispersion or pseudo-exfoliation, normal anterior segment findings, gonioscopy, his angles were open, and no plateau iris or any abnormality in the iris configuration. Fundoscopy was cup to disc ratio of 0.65 in the right and 0.75 in the left, otherwise unremarkable. His central cornea thickness was average, and his visual field showed nasal step in both eyes. What is your treatment plan for this patient? Everyone, just keep in mind, put a treatment plan for this patient. You don't have to tell me, just put a treatment plan in your mind. Hence it comes, collaborative initial glaucoma treatment study. What should we do first? So the purpose of this study is to compare initial treatment of newly diagnosed glaucoma, like this Jamaican man who never been on treatment before. Do we use medical or surgical treatment? That was the purpose of conducting this study. And the main outcome was visual field progression or quality of life. And also the secondary outcomes were intraocular pressure changes or visual acuity or cataract formation. So again, the method was a randomized controlled trial, more than 600 patients involved in the study. They included all chronic open-angle glaucomas like pseudo-exfoliation, primary open-angle glaucoma, pigment dispersion glaucoma. The pressure more than 20 and visual field corresponding to optic nerve head changes, or pressure more than 27 with optic nerve changes but no visual field changes. They were randomized to either medical or surgical. The medical went by the way of medicine first, then ALT, and then TRAB. Beta blocker was the first, then they added other medication. Surgical group was, they started with TRAB, ALT, and then medicine, and then repeat TRAB with 5-FU. So if you notice, both arms had similar treatments, but the difference is, what should I start? Should I start with medicine or should I start with surgery? So that's where the CIGTS goes in place to answer this question. And they define failure as when IOP was more than target or they had a specified visual field loss. They were aggressive, so they used 30 to 35% reduction from baseline IOP. So the results were with in regards to visual field, surgery, the surgical group had more visual field loss in the first few years, but no difference at 5 years. In terms of quality of life, surgery had ocular irritative symptoms, which mostly did not last after 2 to 3 years. Medical systemic side effects secondary to the eye drops also were not consistent among the different patients. In terms of visual acuity, the surgical group had reduced initially, but no difference at 4 years. Surgical group had increased need for cataract surgery, which is obvious. They underwent surgery, so their cataract will worsen. The visual acuity was worse in whites, older patients, and diabetics. In regards to intraocular pressure, both strategies were effective in lowering the intraocular pressure. Surgery had lower eye pressure. They had 14 to 15 versus 17 to 18 for the medical group, but no difference in protection of visual field over the follow-up period, which was about 5 years. Now, one should say, what happened to these same group at 10 years? That would be, of interest. But I mean, they did their best. They followed them for 5 years. We know that following patients for a very long time is not an easy thing to do. Visual field loss decreased substantially if IOP maintained less than 18 millimeters of mercury. So again, with this last point, we are repeating the same findings that we got from the advanced intervention glaucoma study. So in summary, more visual field loss and more visual acuity loss and cataract incidence in surgical group, but no difference at 5 years' time. Few patients develop serious visual acuity loss after either treatment. So few patients did bad whether you choose surgery or medical. Surgery more effective at lowering intraocular pressure. If you need to achieve more IOP lowering, surgery is your best bet. Quality of life similar between the two groups for the long term. Yes, in the initially in the surgical group, they were more irritated and all, but at the end they had a similar quality of life. So the conclusion of this study: initial medical therapy is probably equal to surgical therapy. No reason to change current treatment approach for chronic open-angle glaucoma if you have someone with controlled pressure. You don't have to change it. Intraocular pressure of less than 18 millimeter of mercury was protected in these patients. Now, some notes: there are some problems. There was no trab with mitomycin C. They used the 5-FU. They didn't have mitomycin C, which boosts the success rate of trabeculectomy. So maybe the answer now is different. And they did not have prostaglandin analogs at that time, which could have boosted the medical therapy. But this is a work that deserve we look at it and see what they came up with. Early manifest glaucoma trial. The purpose of early manifest glaucoma trial is to answer questions: do patients with a newly diagnosed open-angle glaucoma benefit from reducing intraocular pressure? Explore factors related to progression and natural history. Outcomes were visual field loss or optic nerve changes. Again, this is an RCT. It included 255 patients. They were either primary open-angle glaucoma or pseudo-X or normal tension glaucoma. Early visual field defect with mean IOP of less than 30 and no single IOP more than 35. Otherwise, they will not be considered early manifest glaucoma trial. They will consider them advanced stage. And they randomized these people into control arm, no treatment, or treatment arm, 360 degrees ALT plus bipaxolol. Xalatan added if IOP was more than 25. If IOP is still high, they will undergo individualized treatment. Endpoint was progression of field and or optic nerve disc. So the results at 6 years follow-up. In regards to pressure, the treatment treatment in lowering IO pressure on average 5 millimeter of mercury was 25% reduction. Progression of visual field or optic nerve changes, 30% reduction in rate of progression in treatment arm, meaning 45% versus 62%. So the progression in the when you lower IOP by 30%, you are reducing the progression by 45%, 45% only progressed. And when you look at the control arm, which received no treatment, they had 62% progression. So again, we're back to the point of intraocular pressure lowering, which is by far the most significant message that we should get from these RCTs, is that it is effective and it is probably the only way to reduce progression in glaucoma patients. 25% increase in mean time to progression in treatment arm. Meaning, when does the patient progress? Like in 2 years, 3 years, 5 years? So there was increase by 25% in the mean time to progression in treatment arm. So if you treat someone they might get their progression in 5 years, but if you don't treat, they may get their progression earlier, like in 3 years. That's 66 versus 48 months in treated or non-treated group. So the untreated group progress quicker. Cataract formation was more frequent with the treatment group. So that's a negative. Risk factor for progression, from baseline factors, older age, higher IOP, worse mean deviation, and pseudoexfoliation. And now if you notice, these risk factors keep on repeating themselves, like in all the studies, like even though they were done for different roles, but the risk factors keep on repeating. So we know what the risk factors in general when we're done. Follow-up factors, change in IOP. Every 1 millimeter mercury reduction in IOP from baseline was equal to decreased risk of progression by 10%. Disc hemorrhage, likely to see progression in that area if you see a disc hemorrhage. So early manifest glaucoma trial summary or clinical practice points are: reduction in IOP beneficial in preventing progression of visual field defect. Patients should be treated, especially when not monitored closely. Those are for remote patients and patients who do not usually attend their appointments. 1/3 of patients showed little to no progression without treatment. So there is a 1/3 will show no treatment, and this was very similar to the ocular hypertension finding, which we will look at. Individualized treatment, patients vary in their response. So sometimes you have to individualize treatment for a particular patient. Consider patient factors such as age, intraocular pressure, disease severity. Disc hemorrhage on follow-up is a sign of increased risk of progression. Half patients still progressed with treatment. So a conclusion of this study is provide evidence for reducing IOP in early glaucoma. Reducing IOP delays progression of glaucoma. Each 1 millimeter of mercury in IOP reduction is equal to 10% decreased risk of progression. This is another case, just to simulate your thinking. 43 years old man with unremarkable post-ocular history or past medical history, no medication and no steroid use in the past, no family history of glaucoma. Pressures were 24 on the right and 25 on the left. Cup to disc ratio were 0.3 vertically on the right and 0.4 vertically on the left. Visual fields both are normal with PSDs of 1.4 decibel on the right and 1.5 decibel on the left. Central cornea thickness was 578, a little bit thick on the right, and 581 micron on the left. So they are above average. Would you treat this patient? So what are we dealing with for this patient? We're probably looking at an ocular hypertension patient. Never been on treatment, no history of glaucoma. Would you treat or not? Someone, when you see a pressure of 25 or 24, you panic and say, oh, let me stop treatment. I mean, I can't say you're wrong, but you need some evidence and you need some help, to guide you. We all face this kind of situation where you have a patient, or you're on the edge. You say, is this glaucoma? Is it not? Should I start treatment? Should I watch them? You kind of wonder. Okay, so let's look at what people's response. Would you treat this patient? Everyone, please answer in the comment chat. Just say yes or no. And I know if you say no, then you will follow them up. Okay. Okay, we have a fair bit of people who are saying do not, and we have some people who want to treat. So who's gonna help us now answer this. Okay. Let's see here. Okay, here comes the OATS, or the Ocular Hypertension Treatment Study. It helped us, decide on these patients. So the purpose of this study was conducted to answer the question: does reducing intraocular pressure delay or prevent the development of POAG in ocular hypertension? And also the question: the safety and efficacy of topical ocular hypertensive medication. It's also a randomized controlled trial. They involved over 1,600 patients with ocular hypertension, and their pressure had to be in the range between 24 to 32, either in one eye or in the fellow eye. No evidence, they should have no evidence of damage from glaucoma, meaning normal discs and normal fields. They randomized them to two groups, either medical group or like a medication group, or no treatment. They reduced IOP by 20% by means of any medication. However, they can get it, but they got them down by 20%, and they noted their results. Let's see what they found at 5 years. Developing of POAG, it was 9.5% in the control group, and it was 4.4% in the treated group. Therefore, now look at this, these numbers. It doesn't always sound as it is. You can tell the patient that we can reduce your chance of developing POAG by 50% by treating you. But is that true? What do you think about it? Is that true? Like, if you look at the numbers, yes, the control group progressed to about 10%, and the treated group progressed. The treated group progressed to about 5%. So the difference between 10 and 5, that's about 50%. It is true by the relative risk. This is a relative risk or cumulative risk. It's not the true number. That means you have to, in the control group, let's say you involve 1,000 patients and then 10 of them progressed. That means you had to treat 1,000 patients to prevent 5 of them from developing glaucoma. And by the way, the definition of developing glaucoma in Oates' study was to show the first visual field defect, the first significant visual field defect, which is by Anderson criteria. If you remember, they had to have a 3 cluster of points in the area that's related to glaucoma, meaning the patient might be even asymptomatic, but you have to treat a number of people. So let's look at, this is the ocular hypertension treatment study, reduction in cumulative probability of developing POAG. Yes, it says 53% reduction, but the numbers are not read as you see them here, because if we leave them alone, okay, 10% with them, 10% of them will develop the first visual field defect. That means 90% did not develop glaucoma. So the actual number is, if you tell that patient, there is a smaller risk that you may develop glaucoma, but it's not, it doesn't sound as it is when we say it. If we say, I'm going to reduce your chance by 50%, no, we're wrong. We're not going to say that. We say you have a probability of developing the disease by about 10%. And if we treat you, we can reduce that 10% to 5%. That's how it should be communicated with the patient. Not like what the drug company, show it. So I just want to point that out so people know how to read the numbers. So the results, there's little evidence of safety concerns with treatment. So that's not a problem there. Predictors for developing of POAG were older age, higher IOPs, higher CD ratio, vertical and horizontal, higher visual field PSD, more than 1.98 decibel, and thinner corneas, less than 555 micron. Okay, predictive for developing POAG, family history, race, African and Hispanic. And also they say the racial effect may be due to thinner central corneal thickness, but it was found. Sex, male, also had worse prognosis. Heart disease, maybe due to vascular problems and nourishment to the optic nerve. Migraine and myopia. Diabetes had a controversial, answer. They said diabetes was protective in this study. Is really diabetes protective from developing POAG, or was it because we excluded patients with proliferative diabetic retinopathy? So that means bad diabetes were selected out from the beginning. Maybe that's the reason. But it was found to be protective in the sub-analysis. So results of OATS: when deciding to treat, you must consider low risk of developing POAG, baseline risk factors predictive of developing POAG, health status and life expectancy, meaning don't tell me you want to treat ocular hypertension of someone who's 85 years old and their life expectancy is not that many years, and they have all sorts of health issues, and you want to put them on a beta blocker. And then also burden of long-term treatment, side effect, cost, inconvenience. Let's say someone barely living on cost, and they have to buy their medication, and you want them to buy prostaglandin every month. And what are you trying to do? So there are factors that you have to consider, and we have an evidence that support us if we say so. So I like this number. See the number needed to treat, NNT. It was 42 patients for functional damage. We needed 42 patients to treat 42 patients. We needed to treat them for 5 years to prevent patient from developing visual field loss. And not a significant visual field loss. That was to develop the first detected visual field loss on Humphrey visual field test. That means even those who we detected means they're not blind, they just have a visual field defect. But we needed to do 42 patients in order to prevent only one. Let's see how much of a burden is that on the economic side. For this, you need 2,500 bottles of Lumigan times $70. That's about $175,000 you spend to prevent one visual field loss. And this visual field loss, it's not even symptomatic. See how much the burden. I'm not saying anyone that their eyes do not deserve to be treated or prevented or spent money on, but you gotta be aware, especially if you work in a place where resources are limited, or you wanna have a support of what are you doing? Is this right or wrong? Do you really have to put them on a medication or not? What's the best thing? I mean, they say one of the recommendations of one of the the American HIV prevention groups in America, they went to Africa and educating newborn how to prevent HIV transmission from their mom, and they laughed. The Africans laughed at them and said they will die from hunger before HIV. So they need to breastfeed their children because it's not they cannot use that model in some parts of Africa versus in the US. So you have to look at the financial aspect of patients, of the country where they live, the whole situation. So that's why we have these results here. Ocular hypertension also showed the OATS study showed a very good relationship between central cornea thickness and the hazard ratio of or the risk of developing POAG. It was very clear that people with thicker corneas had more protection versus people with thinner corneas. And also, Oates showed a good relationship between baseline IOP and central corneal thickness. So if you look at the people with thickest cornea and lower IOP had the least amount of progression to POAG versus those with the thinnest cornea with the highest pressure, they had the worst rate of progression to POAG. And then again, also it showed very good linear relationship between vertical cup to disc ratio and CCT. People with thicker cornea and the least amount of vertical CD ratio had the least amount of developing POAG versus those with highest vertical cup to disc ratio and thinner corneas showed a higher progression rate to POAG. So Oates' conclusion, medical therapy beneficial in delaying onset of POAG in Oates. Only 10% of ocular hypertension progressed to glaucoma at 5 years. Not every patient with elevated IOP requires treatment. Decision to treat should be individualized. And they also found risk factors for POAG, and they developed something called the POAG risk calculator. And this calculator, I do recommend for everyone to try to use this calculator, even in your medical practice. They do have a PDF that is online. You can download it and you can have it ready in your clinic. You can incorporate it into your EMR and then use it for every patient and even document every patient's risk factor of developing POAG. And based on that, you can treat or not treat. So the recommendation of both studies, Oates and European Glaucoma Prevention Study, those two studies, they got together and put a calculator. And this calculator will calculate the risk of POAG at 5 years. So you can tell the patient in the next 5 years, this is your chance of developing POAG. So what was the recommendation? They said, if the calculator gives you a percentage of 5% risk, do not treat. There's no point. There's no enough benefit, okay? If the risk calculator shows you 15% risk, then it's better to treat. And that's based on evidence. But if you fall between 5 to 15%, then you individualize and discuss with patients. You know, some of them, what does that mean, individualize and discuss with patients? If the patient tells you, you know, I have 2 brothers who went blind, my mom and my dad went blind at their late ages, and now I have a pressure of the same case that we discussed earlier, and most people say no treatment. But if that particular patient tells you, I do have a strong family history, 2 of my siblings went blind, and you watch this happening, then you cannot just say, oh no, you fall into, you know, 3% of the risk calculator, we're not going to treat you. No, look at their risk factor and then decide from there. So what I'm going to, this is the calculator. This is how you find it in the PDF format. What I'm going to do is I'm going to pause this for a bit, and then we're going to go and just find it online. I'll show you how to find it online. You still see my my screen here? Okay, so you go to ocular hypertension risk factors or POAG risk factors to Google and just search it. And this first result come out here. Just click. And then you have the ocular hypertension treatment study. You go down, scroll down, and you have you have two ways of doing it. You either use the continuous method or use point system. I like the point system. So click on this, and here it comes. This is the PDF that you have. So what I'm going to do is now apply that same patient that we had earlier. So let's look at their risk. Maybe minimize this. Let's put them together. We'll do a live example here, okay?
Yes, very interesting. Thank you.
You're welcome. Okay. I'm just gonna go. Okay, here we have an example here, okay? Let's look at that. Let's plug the information together. Okay, so we have a 43 years old man with unremarkable POAG. Okay, so first thing on the table, it says their age. So 43, we should check here. They have 0 points factor on the age. No family history of glaucoma. Their IOP is 24 on the right and 25 on the left. We're going to select the worst case scenario, okay? So where does the 25? It's here. So you have, we're going to select between 24 to 26. So right there. The next point will be central cornea thickness. Their central cornea thickness is 578, 581. We'll take the thinnest one because that's more risk. Okay, so where does that fall? So it's right here. Okay. After that, visual vertical cup to disc ratio. His cup to disc ratio is 0.3 vertical on the right and 0.4 vertical on the left. We'll take the worst one. We'll take the left eye, 0.4. Okay, so we'll go here. We'll select this one here, 0.4 to 0.5. And then visual field PSD. Whether it's a Humphrey or an octopus, you have values for both. So his Humphrey visual field PSD was, we'll take the worst one, 1.5 for the left. So 1.5 is right here. It's less than 1.8. What else we need? Okay, now we're done. So, okay. So we'll magnify this. So once you click all these points, you automatically get the results. And the results is estimated risk is 4%. Okay, you can print this. You can click here, print, give to the patient, put in their chart. That means you have calculated the risk and you have come to an agreement with them based on evidence that they need treatment or they do not need treatment. Either way, you are supported. So we're going to go back now to our presentation. So based on oaths, would you treat this patient? Remember, we had answers for this before, and some people said yes, some people said no. Those who said no are, right, based on evidence. Those who said yes, I mean, this could change if we change one factor here. If there was family history in this person's life, and they had siblings lost vision and let's say parents or something, and then I would definitely not look at anything else, and even not at the risk factor calculator, and I would treat them, but not in this scenario. So the answer based on evidence is no. The risk factor is 4%. Observation is probably enough. So where to find this calculator? As I said, you can find it on Google directly from Google search, or you can download an app called iHandbook. It's available for both Apple and Android. Pfizer used to have an actual calculator, like a physical calculator for risk. They stopped, manufacturing them because just, you don't need it because you have it on your cell phone now. This is how the app looked like on the eye handbook, looked like this. And then you can find the calculator there among the calculators. And when you open it, you will find this glaucoma risk calculator, and you plug in all the numbers and calculate the risk right from your smartphone. So take home message, landmark studies or RCTs with most and highest evidence all together agreed that lowering IOP will reduce progression. If reducing eye pressure by modest amount, many will still progress. This was evident by early manifest glaucoma trial. Every millimeter of mercury reduction helps, and that was found in early manifest glaucoma trial and advanced glaucoma intervention study. Aggressive medical treatment equal to early surgical treatment. That was provided by collaborative initial glaucoma trial. If IOP less than 12 millimeter, most patients will not progress. And that was found by advanced glaucoma intervention study. Normal tension glaucoma is strange. It's a strange entity. Many do not progress, but if progress, the only proven treatment is reducing intraocular pressure. Normal tension glaucoma study. Not all ocular hypertension need treatment. Assess risk factor and on an individual basis and discuss with patients. That's from the OATS study. Understand how target IOP achieved and how to individualize patients' treatment in order to know how to apply findings to your practice. Thank you very much, everyone, and we're open for questions.
Jazakallah khair, Dr. Gdih, and thank you very much.
And I think it's exactly 50 minutes.
MashaAllah, naam. Time management, mashallah. Thank you for two things. The first one is for the informative lecture, as usual. And second, for your way in education and teaching by examples and taking our hands step by step. I love this way, actually. Thank you very much.
You're welcome.
Now, Dr. Munir.
Yes, thank you very much, Dr. Gdih. That was beautiful as usual. I learned a lot, actually, and you reminded me of all the conclusion, which sometimes I forget about. So I think that was very useful. I just want to possibly add a couple of studies. They are not RCTs, possibly, or they are RCTs, but they are not as important, but because they are very recent. So I thought there is no harm of reminding the colleagues about the outcome. The first one is the ZAP trial, which was published only 2 years ago. Obviously, this is about comparing, in cases with the primary angle closure suspect, whether to do YAG-PI or not to do YAG-PI. So this study was done in China, and it was a huge number. I think 1,000 patients were recruited. So what they have done, they defined the primary angle closure suspect as 180 degrees narrow angle, almost with the irido-auricular contact, without increase in the pressure and without pass. That was the definition of the primary angle closure suspect. So they did YAG-PI in one eye, and they left the other eye for observation only. And after 5 years, they found no significant difference between both eyes, really. So they concluded that YAG-PI in primary angle closure suspect is not indicated unless this is a patient with high risk. So when we say high risk, it's a patient who are extremely myopic, patient who are having regular dilation for their pupil because of the diabetes, for example, or patient with family history of angle closure glaucoma. So these three categories, they said, okay, possibly it's worth doing the YAG-PI, but for anything else, they stopped doing it. The other thing is they recommended people who are coming from abroad, they have no access to hospital, just in case if they have angle closure episode, they may have it as well. And this changed the practice a lot actually, but the only limitation of this study, it was done on Chinese people. So that's why possibly there is no validation for other races. So that's one study. The other study is the famous light study. Again, the conclusion was possibly we need to offer SLT treatment as a kind of primary treatment for people with the early glaucoma or ocular hypertension, because they found that it can be as useful as the drops. Thank you.
Thank you very much, Dr. Munir.
Thank you.
Should we go to the questions?
Yes, please. There are two questions, Doctor.
Yes. One is asking, what do you mean by multivariant and univariant? These are, I am not the best person to answer these because mostly a statistical way of, it's just a method of analyzing the results. So they, I think what they mean by multivariant, meaning incorporating many variations that happen in the study or a particular variation. But I'm not good at explaining it. It's just a statistical, you can call it a vocab that they have.
Yeah.
What is your management if case with ocular hypertension developed to glaucoma despite receiving treatment? Again, we talked a lot about individualizing treatment. Not everyone will follow a certain pattern like these studies are showing, but for the majority, you can apply these recommendations of these studies. But some patients, you need to take a different route. And for that, if someone developed glaucoma despite treatment, then I would probably maybe, they might go into another category. Maybe now they're in the advanced glaucoma intervention trial. So they go into another category. We don't necessarily need to keep them in the types of patients that's in the OATS study. So they jump into another category. So we treat them as we would treat, you can derive your treatment decision from the ages instead of from OATS when they go into that.
Yeah, there is another question, but it is in the chat, not in the Q&A. When to treat normal tension glaucoma suspect?
Normal tension, yeah. So that's another thing, it really depends on the risk factors that we talked about, whether or not they have associated risk factors like, myopia, migraine, family history. It really, and if you don't treat them, 2/3 of them will not change. So yeah, again, it's there's no direct answer to this. You just have a group of risk factors. You keep them in mind when you see the patient, and then you judge from there.
Now, I think regarding the first question, the univariant and multivariant, I think statistically, when there is univariant, it means that we are studying only one factor. For example, if we are studying the effect of age or gender, and we fix all other multifactors. So we choose, for example, if we are studying age, then we may study all patients are females and all from the same area, for example, all are receiving the same medications, all are in the same stage, for example, and they are different age group. So in this case, we are studying only the effect of age on this, on the output or outcomes. Multivariant means that we have many factors are being studied at the same time. And of course, they will need sophisticated statistical analysis in order to discriminate between this and that, and to know the extent of effect of each factor on the outcomes. So it will be like very big study.
Mohammed Sultan is asking, do you agree that the surgery is still the gold standard treatment for POG in the Arabic world? Whether Arabic world or different world, again, you do have evidence. If you want to treat with surgery, you do have evidence, like as an initial glaucoma, collaborative initial glaucoma treatment trial, it showed that if you start with surgery or start with medical, you're probably going to end up the same. So it's not wrong to start with surgery. And again, this was done back when they had no prostaglandin and they had no mitomycin C. So things might change now, but you do have evidence that they did the same back then. Yeah, and thank you, Dr. Mazen, for answering that question.
Pleasure.
Make 100%.
Maysoon is asking in the chat as well, would you wait till having visual field defect? She means in the normal tension glaucoma. Do you wait until you have visual field defect? And what is the target IOP in normal tension glaucoma? If no FH,
no family history,
symptoms, no family history or other symptoms, would you depend on disc shape and OCT findings?
Yeah, again, so for the normal tension glaucoma, I mean, waiting for a visual field defect or not is not a deciding factor. I mean, I would treat someone who has a visual field defect, but would I treat someone who do not have a visual field defect? I would probably do, if based on other risk factors. And again, the shape of the disc and the OCT findings, which will allude to the structure of the optic nerve, all these things are tools that you use to whether or not you're going to treat or not. Again, we go back to each single study of them and then see what were the risk factors. And I have included them in the presentation. If you go back to it, you will see like the vertical cup to risk ratio. The higher it is, the more likely, and also the family history was important factor. Again, there is no one recipe that you can give for every patient. You just have to look and then decide from there. Like if you put examples together, and then we can make a decision. Like we can talk about whether this patient needs to be treated or not.
Mm-hmm.
Yeah, so I don't, just to make it short, to answer your question, no, not necessarily I will wait for a visual field defect. I could treat someone with a perfectly normal visual field defect. But again, based on the presence of other factors, other risk factors.
Yeah,
target pressure in normal tension glaucoma, if you want to use a rough number, you go by reduction of 30% from baseline. But again, that's another thing, and maybe Dr. Mazen in the advanced course we can talk about how to set up a target pressure, and we can talk for hours about that. How to set up a target pressure. Yeah.
Exactly. Yeah. Thank you very much.
Welcome.
I think no more questions, no more. Yeah. Dr. Munir, anything to add?
No, that was very clear actually, and Dr. Gdih, he just summarized all the findings in a beautiful way. I think just commenting about this last question Dr. Maysoon mentioned, I usually, because with normal tension glaucoma suspect by definition when there is no visual field defect as such, especially if this is not consistent with the shape of the optic disc. So if the optic disc is suspicious, especially on the retinal nerve fiber layer OCT is thin or the disc margins are thin, I would observe initially, especially if no family history of glaucoma and no evidence of visual field defect, and especially if the age is kind of like she's elderly or he's elderly patient. I usually check the CCT again just to exclude very thin cornea. But apart from that, I would observe once I see any change on the disc or CT or very early field defect, possibly I would consider treatment again according to the other factors, but I wouldn't start initially without any evidence, because once you take the decision to treat, it's a decision for life almost, unless if you would like to consider SLT, which could be just one session to do. But the treatment really, especially if this is young age, I would make sure this is glaucoma before starting the patient on treatment.
I agree. Thank you.
Thanks.
Thank you, Dr. Munir. So by this, we can conclude this session. Thank you very much, Dr. Gdih, for your time, for your effort, for the science that you are giving. Thank you, Dr. Munir, for the discussion, fruitful discussion. And I'd like to thank as well the attendees for being with us. And hopefully we can see you next month, inshallah, with the next session. Good night, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam. Thank you very much. And